although the subject is extremely exciting, I thought the intro to it, as important because it sets out the outlines of what are we going to discuss and what we should agree upon. And that's why I started with this slide. This is an apple. I don't know if you've seen the CNN advert. It's anti-Trump advert, and it talks about setting the facts as they should be. So you call an apple and a banana a banana. And that's why we should set the facts in peripheral revascularization, lower limb vascularization, in a very brief, short moments of time, as they are. And once our discussion stems out of fact, I do not think we do have a lot of space or place to disagree upon what we should do and what we shouldn't do. And there's a reason I say this, because there's a lot we see gets done that shouldn't be done, and there's some things that should be done are not getting done. That's why I did not fill my 10-minute presentation with angios of things I've done or amazing surgeries I've performed. It's not the space or the place for it. We're just going to go quickly through the basic facts and hopefully we agree upon them. And why are we talking about this? Because the spectrum of lower limb insufficiency covers a few symptoms, which includes the usual intermittent claudication, the critical limb ischemia with stress pain, ulceration, gangrene, and the acute limb ischemia. So it's a whole set of diseases and processes that are so wide and variable. However, they meet in one point that they intend to revascularize the lower limb. And why is it important? Because of this diagram. If you compare lower limb ischemia or ulcers, especially neuropathic ulcers, to any of the non-malignancies, or if you compare the peripheral vascular disease as an entity to any of the non-malignancies, you will find that only 2 malignancies worse than having peripheral arterial disease, pancreatic and lung CA. Everything else is better. And that's when we're talking about the 5-year mortality for patients with ischemic ulceration, neuropathic ulceration, or peripheral arterial disease. It's very important, however, not just because of the mortality, it's because of the massive morbidity that attaches to it. Dying is not the scary thing, it's dying in pieces that is. Amputations. Amputations are a serious predictor of death and a major influencer of the quality of life. And as a predictor of death, especially in diabetics, you're very unlikely to be alive if you get an amputation, whatever amputation it is, in 5 years following the amputation date. And that brings us tragically to some tragic rules. And these are the tragic rule of 15 and the tragic rule of 50. One of my areas of interest are wound care and wound healing. And we find these rules, when applied, that you're not intending to give the patient an everlasting solution. You're intending to get them through their next year and the year after with a reasonable quality of life, intending them to be served by their lower limbs rather than serving their lower limbs. So the tragic rule of 15 states that 15% of diabetics will have a foot ulcer in their lifetime, 15% of those will be osteomyelitic, and 15% of those will have an amputation. 50% of amputations are major amputations, so they're transtibial or transfemoral. 50% of patients who have an amputation will have a second one in less than 5 years, and 50% of all those will die within 5 years. And why is it in a huge importance in our part of the world? Mainly because of these 2 risk factors, sugar and smoking. Risk factors for peripheral vascular disease are quite extensive, and they're well known to all of you, but these 2 have a massive impact, especially in the Middle East. In Jordan, smoking is a massive, massive thing. We rank about 3rd worst country in the world when it comes to rates of smoking. I do have special interest in smoking research, and when I was at the Royal Medical Services, we did a study, a sort of a surveillance study of the incidence of peripheral vascular disease on shisha smokers or happily smokers, only happily smoking, so they don't smoke anything else but this. And we were stricken by the numbers. 18% of those who smoke it regularly do have peripheral vascular disease, one sort or another. And when you get in a society to a stage where there's a shisha taxi which delivers it to your house, then there's a problem there. In Jordan, the numbers are striking. We have 1.2 million diabetics. The incidence in the adult population is about 19% of the adult population. We have 165,000 diabetic feet a year, and out of these, 35,000 will end up with some sort of amputation. These are massive numbers. A lot of them go unnoticed because they happen in public hospitals, in the periphery, in places where they do not get the adequate care. And it reflects the changing population in Jordan, because there is a dramatic increase in the population, and that from the consensus study in 1915, that accounts also for our Syrian brothers who are in the country as well. It's not just the numbers that increase, it's the demographics of the population that have changed as well. So you can see that there is a group of population, which is the 15 to 64, that is predominant in the Jordanian population. This group, most smokers, by the way, started smoking at age 13. One of the most alarming statistics is the rate of smoking in teenagers in Jordan. It approaches 26%, which is massive. So this group, when they smoke for long enough and they get their diabetes in their early 50s or late 40s, they all will have peripheral vascular disease before they get to 65. Once they do, they're on the stairway, the first steps on the stairway up to amputation, which is the risk factors that leads to neuropathy, infection, ulceration, and everything always ends up with ischemia before it gets amputated. And that's why we came up with a model for healing wounds and for dealing with them, which is a very simplistic model, and we're in process to publication of our first 165 cases along this model, which is the ARCC model. So ARCC, quite simple. It manifests that in any wound, you can heal it by doing 4 things: doing the assessment, revascularizing it, cleaning it, and covering it. Emphasis on the word revascularization. A lot of wounds are ischemic, be it tissue ischemia, micro ischemia, or major ischemia. That's one example of such a wound where in all our wounds we follow the same paradigm, where we assess it, we do the revascularization, be it surgically or with an interventional means, and then we cover it either skin grafts, etc., etc. And the results are quite impressive, and I hope I'll share them with you in the next year when it gets published. And there is a shift in the paradigm of treatment for revascularization, where you always target to do single, straight, inline flow to the toe. So pulsatile flow to the foot is essential if you're going to heal anything. You can manage sometimes with lesser degree of vascularity. However, this what will guarantee your ability of using other means to heal a wound if you have straight inline flow. And a straight inline flow to the major vessel supplies of the foot, which are the posterior tibial and the anterior tibial, is preferred to the peroneal artery. There is some discussion about that, and the discussion extends to what's called the Angiosome concept, which is, should you revascularize this area that's supplied by this vessel? We'll come briefly to this. These days, mini is fashionable. And it's not just fashionable, I'm talking about interventions, by the way. It's not fashionable, it's right, I agree with it. That's what I do myself. I think I'm a great believer of the interventional first approach. So if you're gonna revascularize something with lesser potential morbidity, mortality, and we do get into massive discussions with our vascular surgery friends on this, you should do it. Especially that 2 things happen when you use interventional means for revascularization. One, you do not lose your option of doing your surgical intervention. And second, you gain time for whatever you're gonna do later. It's lesser morbidity, lesser mortality procedure, and usually solves the problem. That's why the task classification, which has been around for many years, have focused on what to use in previous years, what to use for certain lesions. But these days, the lines between classes are being blurred, and we're using even an interventional means to revascularize task C and D lesions. Rightly so, the risks are different. The impact on the patient is quite different. I'm not going to go through all the details of these lesions and their revascularizations, but I will briefly touch on the difference between revascularization surgically and interventionally. The patency rate obviously are better with surgery. However, the difference is not massive, it's not far away. The perioperative mortality and morbidity, on the other hand, is greatly different. So you have so much less mortality and morbidity when you use the interventional means, and it's a treatment of choice for a lot of these lesions, especially if it's class Rutherford class 2 or less. An equivalent image happens with the femoropopliteal site or lesions, where you also attempt interventional means before you go into surgical revascularization. And again, the reason we do this is because the femoropopliteal bypass surgery, which is excellent surgery, straightforward, low mortality, 0 to 3%, however, still surgery. And if you can do the same job with interventional means, so be it. Having said that, you should do the job. So interventional means should not be just a step before I do my revascularization with surgery. If it doesn't do the job, either don't do it or add something else to it, which brings the procedure into what's called a hybrid procedure. So you do some part of it as interventional and the rest of it is surgical. Whatever you do, you should make sure that you have inline pulsatile flow to the foot to get healing. Which brings us briefly into the angiosome concept. What's an angiosome? Well, it's a unit of tissue which consists of the skin, the muscle, the bone, the tendons, everything underneath it that is supplied by a single vessel. Everything in the body is an angiosome. In the body as a whole, there are in excess of 40 angiosomes, but the foot has about 5. So I'll go back to that. The foot has about 5 angiosomes, which are supplied by different vessels. There were studies a few years ago which would emphasize that revascularization should lead to angiosomes. Then came a massive meta-analysis which said whichever vessel you revascularize, as long as you revascularize something, it will probably give you the same result. Recently, people are finding slight differences in angiosome revascularization. Personally, and having done hundreds and hundreds of revascularizations, I find if I can do it, angiosome guided, I will, but otherwise I will try to get the next best thing. There's so many other ways coming up sort of in the market and in fashions in the world of revascularization, which include atherectomy devices, debulking devices, rotational devices, subintimal angioplasties, lots of them. I hate changing trends in practices when they're not proven. When treatment of hypertension using a burning catheter to the renal artery came out and people rushed into doing it, it only took a few years to decide this is the wrong thing to do. This is fashionable rather than real science. The same applies here. Atherectomy devices came in a massive waveform from the States, and obviously it's industry-led for people only to realize later, we're not doing the right job. If you have something which works, keep doing it until something better comes along. So what's the evidence for at the moment? Well, it's easy to go through the how to diagnose BAD, and this will not go through. If we know the natural history of these presentations, we know how to deal with them. Well, the first one is the intermittent claudication. The natural history of claudication is very benign. It's a benign disease. That's why I preach to my colleagues, to everybody else, do not touch claudicants, regardless how much money there is in it, how much benefit you get, how low the risk of intervention. Do not touch claudicants. And I do not buy into the idea that you can make somebody walk a little bit better, a distance further by intervention. You should do it. You shouldn't. Why? 2 things. What kills claudicants is their heart, it's not their legs. It's a benign disease. The mortality of claudicants at 5 years is quite high because of coronary disease. And second, you can increase their rate of limb loss if you touch them. So you're not doing them any benefit on the long run. They might walk a bit further for the next 6 months, but if you look down the line in 6 years, their rate of limb loss is higher, and this is research proven. Treatment, conservative for intermittent claudication, unless you're absolutely convinced that this patient cannot live his life at all without you intervening. The usual example is, we don't have postmen or milkmen, but the postman who cannot do his job, or somebody else who cannot walk to the mosque, etc., etc., they earn it, they have to beg for it. That's when you intervene on them. Recommendations, in fact, they support what I'm just telling you about intermittent claudication. And the one thing that you shouldn't do any intervention for intermittent claudications to prevent CLI, critical limb ischemia. So the convincing argument to the patient, بنسوي لك هاي عشان بعدين ما تخرب رجلك, is not valid. It doesn't work. In fact, the evidence, and that's the color red, is this is do harm evidence. So there is evidence that you're doing harm when you do this intervention. Critical limb ischemia, the 1-year outcome is pretty terrible. It's worse than cancer. So the possibility of a patient being alive with 2 limbs at 1 year, which is very short, is about 50%. The rest will either die or have an amputation. And of the ones who survive with 2 limbs, only a quarter of those will have, or half of those, sorry, which is 25% of the original number, will have resolved CLI. So it's not nice disease to have. The diagnostic process, again, I will not go through it, take some time, but I'll go through the recommendations, is that you do an endovascular procedure for CLI when you can to resolve it. If that doesn't work, you do a staged surgical procedure, or you can do a combination of those. If you can use the angiosome-directed revascularization, it will be good. If not, then use any revascularization. Surgical revascularization, distal bypasses, excellent procedure. I love them. I think they're a great thing. They do save limbs. When you need them, you need them. We always use vein for them. There are so many technical ways. I will not get into them. However, they're still associated with some morbidity, slight mortality. So if you can do it interventionally, again, do it interventional means. The last part of our limb revascularization goes to acute limb ischemia. What's acute limb ischemia? It's the ischemia of less than 2-week duration that has the classical ischemic features, the 6 Ps. It's divided into a viable limb, a threatened limb, or a reversible limb, and the slides are available through Mahmoud's publication to go through the details. But acute limb ischemia is an acute problem that needs acute management. And the recommendations are that you should revascularize threatened or viable limbs as soon as you can. And revascularization usually is surgical, especially if there's embolic in source. And if it isn't, then you have the time to plan further treatment. They're usually salvageable if they're caught early. The one thing I don't like using with those is the thrombolysis and waiting in our setting. In different settings, in the international setting, it works. In our setting, it's just delays the inevitable, which is losing the limb. All our patients will need follow-up. Duplex is the best way to follow them up. I'm a great believer of vascular labs that they use, vascular technologists, and provide the service, be it for diagnostic process or the follow-up process. So in summary, claudicants should be revascularized if they earn their revascularization. Inflow and outflow are an assessment process that you always go through to know where to revascularize from where to where. Critical limb ischemia revascularization, especially when there is tissue loss, should be adequate enough to get pulsatile flow to the foot. Direct flow is always better than indirect flow. I finish with this great quote I've always loved for Sir Robert Hutchinson: from inability to leave well alone, that's claudicants; from too much zeal for what's new, that's atherectomy device; from treating patients as cases, that's private practice; and from making the cure of disease more grievous than its endurance, that's most of vascular surgery. Good Lord delivers. Thank you.